30-day window before applications have to be submitted. I want to thank the two board members who are joining us today, two board member volunteers, Jim Piles and Brent Theorine. Jim, who is with Powers, Pyle, Sutter, and Verville, has been our IAH legislative leader. Brent, a consultant and president of Colonnade Healthcare Solutions, has presented on financial management topics at our annual meeting. Gary Schwartz, our Associate Executive Director, has been contributing his skills in practice management and public policy since January and will also be presenting. And I also want to thank Audrey McDonough, our technology guru, who is assisting us today. The plan is for me to go first talking about what we know about the clinical model, followed by Jim, who will talk about permissible legal structures. Brent and Gary will then talk about how to estimate the financial requirements of participation. After that, we hope to leave 15 minutes or so for questions. If you want to ask a question, please type it into the questions chat section of the webinar control on the right-hand side of your screen and click Send. You can also submit questions by sending an email to the AAHCP at aahcp@comcast.net. Please send in your questions throughout the webinar so they can be compiled and we can answer as many questions as possible. There will be a video recording of this webinar available for download. If you are having problems with audio or seeing the slides, please send in your problems using the chat question feature, and someone will be in touch to troubleshoot your problem. So with that, shall we get started? Okay. So my role is to talk about the legislation and what it means for planning. The care delivery model is the place where I'm going to start. We know from the legislation that it has to be physician and nurse practitioner directed home-based primary care teams, and we underline teams. The composition of the teams has to go beyond the usual house call model to include physicians, nurses, physician assistants, pharmacists, and other health and social service staff as appropriate who have experience. And experience requirements are to be defined by the Secretary of HHS. The care delivery model has to be based not on episodic care, but on plans of care that provide comprehensive, coordinated, continuous, and accessible care, must be available not just from 9 to 5 during the week, but 24/7 to carry out the plans of care. There must be use of electronic health information systems, remote monitoring, and mobile diagnostic technology. Additionally, and this is very important and new, there must be provision of care coordination across all treatment settings, meaning that this is not just the house call model, and other criteria as determined by the Secretary. The patient population, the numbers, I think as everyone on this call probably knows, the minimum number is at least 200 applicable beneficiaries during each year of the demo. The diagnoses and conditions make sure that there is a targeting to the very sickest, frailest patients. Patients must be entitled to Medicare Part A and B, not enrolled in Medicare Advantage or PACE, and this is very important, to have 2 or more chronic conditions such as CHF, diabetes, other dementias, COPD, ischemic heart disease, stroke, Alzheimer's, neurodegenerative diseases, and other high-cost conditions as designated by the Secretary. Additionally, they must, within the last 12 months, have had a non-elective hospital admission and received acute or subacute rehab, and must have 2 or more functional dependencies, and such other criteria as are determined by the Secretary. The method for determining patient willingness to participate must be determined by the Secretary, and that is the only specification that is in the legislation on this topic. Quality data and reporting programs must show that they improve the health outcomes commensurate with the beneficiary stage of chronic illness. Programs must improve the efficiency of care. For example, duplicative diagnostic and lab tests removed. Programs must provide patient and family caregiver satisfaction and must report on quality measures in form, manner, and frequency as specified by the Secretary. In other words, there is going to be both quality measurement reporting required and patient and family satisfaction reporting required as well. The payment methodology. This is a key issue for everyone. Providers will continue to bill and collect fees under the Medicare program. No care coordination payment is included in the legislation. On shared savings, cost data will be collected by CMS, and per capita spending targets will be established by CMS using a methodology they will determine. Only those practices, IAH practices, who have made payments, who have made savings of 5% or more, will be eligible for an incentive payment. That's the term used for the shared savings that we are talking about here. So with that, questions to ask about in terms of your practice. Do you have adequate numbers of patients with the required characteristics? Do you know what the characteristics of your population are? If not, what can you do to meet the required numbers? There have been I've had lots of discussions with Academy and other members who are talking about how to go and increase a referral base for this, that, or the other condition that they don't currently have, or to establish relationships. Do you have the right leadership and composition of your teams? If not, what can you do to strengthen your operation? I've talked with people about the need to recruit, funding, training, how they're going to be able to pay for a social worker, how they're going to be able to attract a pharmacist to be part of their teams, etc. Do you have remote enough EMR and other technological capabilities? How will you promote efficiency and remove duplication? If not, how will you do whatever is required by CMS? This is an area where CMS will, in fact, specify what the minimum requirements are, of course. What is your workaround for the lack of interoperability between information in various settings of care? This has been another topic of discussion. Nothing is going to change radically overnight, so the issue of whether you know where your patients are going and how you're going to manage the relationships is unchanged by this legislation. Given that you must save at least 5% to be eligible for the savings share, how are you going to define those things that are going to cost you more? For example, 24/7 coverage, care coordination. How are you going to prevent unnecessary ER visits and inpatient admissions and readmissions, so that you come in under what the normal, what the expected care target would be? How are you going to handle the quality measure and patient caregiver satisfaction requirements? Do you have adequate trained staff? If not, how are you going to get them? Then how are you going to run the IAH program segment of your overall practice? Or will your whole practice need to migrate to this model? How much incremental cost will there be? How are you going to handle the issue of the fact that the financial rewards may not be at the beginning, maybe more toward the end, and the issue of what will happen if in fact there may be very nice financial rewards coming, but there could also be quite limited ones. Resources to help you, that's where I want to end. Want to be sure that you know about our Home Care Medicine Field Guide, which is a comprehensive document that gives you best practices, including some of the material that we've recommended to CMS about how to evaluate home care medicine practices. The clinical practice guidelines that are part of that document or can be bought separately are also a good place to start. Again, these are things that we have recommended to CMS that will give you a chance to benchmark. There are also technical assistance and practice management services available through the Academy. I've given the website there. These are all things that, if you don't already have them in your possession, may help you as you think about and plan. Lastly, I want to mention that there will be an on-site meeting about IAH in the Capitol Visitor Center on September 22nd. The details will be followed and will be to follow and will be provided in an email invitation. But basically, we are hoping that the specifications will have been issued by then, and this will give you a chance to get the questions asked and answered that you need to have. So watch for your email announcements of the September 22nd meeting, and certainly for the announcement of the release of the specifications. So with that, I'm done, and now can I turn it over to Jim?
Thanks, Connie. Thanks a lot. And I'm going to run up my PowerPoint here, and hope that's visible to everyone. What Connie has described has been really the Independence at Home demonstration project that is in the health reform legislation. And one of the points I would like to make is you can think of Independence at Home. I've worked on this model now for about 10 or 11 years or so, and it is a model that works in any health insurance program, whether it's Medicare, Medicaid, or private insurance, or Medicare Advantage. And it is true that the demo is going to be rolling out this year, but the demo is limited to 10,000 beneficiaries and organizations that will have a minimum of 200 patients. So it's likely that not everyone who wants to participate will be able to do that. That doesn't mean that you cannot run an Independence at Home organization. You can certainly do an Independence at Home clinical, legal, and financial approach with private insurers who are quite interested. Medicaid programs, and self-insured companies or programs as well. So I'm just going to jump through a couple of slides here. I'm not going to duplicate what Connie had said, but very generally, just understand that Independence at Home is an idea whose time really has come, as some of you, obviously, most of you, I'm sure, see. We're in a position now where we absolutely must control cost of health care in this country, and we know that the cost is tightly compacted into the top roughly 5% or so, 5 to 25% of beneficiaries. So Independence at Home is one of the few clinical and legal approaches that actually targets that beneficiary population. As I show here on slide 3, we're getting interest from all kinds of health insurance plans, and so think of this as more than just the Medicare. Hang on, let's see here. Somebody's trying to get in touch with me. Hello?
Right, left. No, the little bit. No, left, right. Third icon, there, go there.
Okay.
Click. Sorry.
Can you hear me now? Okay. The dial-up box. Oh, I see. Okay. Yep, Zoom. Okay. Right. There. Okay. Can you hear me now? Can they hear me? Okay. Sorry, I understand that you couldn't hear me, so I'll just repeat what I was saying here, which is that Independence at Home is more than just a Medicare demo. Connie was essentially describing the demo, which will roll out this year. But it is more than that. It is a a health reform program that can be used with any kind of health insurance, whether it's Medicare, Medicaid, or private insurance. I've listed for you on slide 4. I guess you all could see the slides there. Some of the unique features of independence at home, and it really is a unique health reform proposal, both in terms of the patients that it addresses, the very high-cost patients it addresses, and also the kind of unique reimbursement that it provides. But how do we get there? On slide 6, you'll see there we have independence at home as a demo, as Connie was talking about. It can be used in Medicare Advantage, Medicaid, with dual eligible programs. Also, there's a program for pre-existing, those individuals have pre-existing conditions that CMS is trying very hard to enroll people in. And independence at home, we've talked with the CMS people, and independence at home would be a very good program for that patient population as well. So it's not just a Medicare demo. The essence of independence at home, you'll see on the next slide. My former partner, my deceased partner, Galen Powers, used to say that if it makes good business sense, it's probably illegal. And that's true, because the Medicare, Medicaid anti-kickback law and the Stark laws put a real limit on the kinds of arrangements that have been possible in the past. The anti-kickback law, of course, prohibits intentional payment in return for referrals or service, and the Stark law applies to certain designated services for which, and it says that physicians can't make a referral to an entity in which they have a financial relationship for the provision of designated services. Now, the things we know about independence at home is under the legislation, and this again is under the demo, and only under the demo. It must be a practice and must be comprised of physicians and nurse practitioners, but it may include other types of providers and practitioners as well. There is the things you should consider, of course, are the federal anti-kickback and anti-referral laws, but also the state corporate practice of medicine laws and fee-splitting laws. And then you're going to have contracts that allocate losses, gains and losses. Tools to reduce risk, there is a provision under the demo legislation that provides a waiver from the anti-kickback and Stark laws, and it is the same kind of waiver that is permitted for ACOs. And we saw when the ACO proposed regulations came out on April 7th, we also saw proposed regulations on the waiver that would apply to them. So we can be fairly confident that the waiver that independence at home is going to have will be similar. And it provides for a waiver of the anti-kickback and the Stark law for shared savings distributions for participants in the program, for distributions to others if those distributions are necessary for and directly related to the program. They can also be made, distributions can be made from a hospital to a physician, but I'm not sure how applicable that'll be to IAH. Remember that the waiver authority under independence at home, as well as for the ACOs, doesn't apply to Medicaid, but the CMS Innovation Center does have waiver authority for Medicare and Medicaid, so it's going to be interesting to see whether that waiver authority is broadened by the CMS Innovation Center to cover both Medicare and Medicaid. What if you don't qualify for a waiver? Well, you can still steer around the anti-kickback and Stark laws. Home-based primary care, which is what is provided under the independence at home provisions, is not a designated service, so the Stark law shouldn't even apply. And the Stark law has a whole raft of exceptions, and there is one for physician incentive plans, as long as you provide necessary services. There's also one for employment relationships and risk-sharing arrangements. All of those are exceptions that could apply to an independence at home program. The anti-kickback law also has safe harbors for employment relationships and risk-sharing relationships. And the state corporate practice of medicine laws are somewhat different in each state, but I've reviewed all 50 states, and they essentially say that corporations cannot employ a physician to practice medicine. The idea is corporations should not be making medical judgments, physicians should be, or if it's permitted, nurse practitioners in your state. But there are exceptions, and the exceptions that are common are for hospitals and to employ physicians, professional service corporations, and HMOs. Actually, what I'm giving you here is a summary of Maryland law, which is pretty typical of corporate practice of medicine laws across the country. These laws typically don't address whether physicians and non-physicians can be in the same limited liability company, which is one of the models that could be used. Fee splitting essentially says that a physician can't split fees with someone for bringing or referring a patient to them. They can't typically. This is the sort of thing that comes up with physicians referring patients from one to another. What legal documents will you need to create an independence at home organization? You're going to need an agreement with the payer, whether it's Medicare, Medicaid, or private insurance. An agreement among the practitioners who are participating on how the savings sharing or perhaps losses will be distributed. An agreement with contractors if you contract for any services out of the independence at home organization. And of course documents to establish the legal entity, whatever you decide that might be. So what are the legal models that you could use? Well, you can have just a physician nurse practitioner group that contracts with others for all the services you need. You'll need a joint operating agreement. Certainly going to have to avoid the anti-kickback issues. You could have a joint venture involving a practice of physicians and nurse practitioners joined by other types of providers and practitioners. Probably the best way to do that is with a limited liability company. But you must make sure to reserve medical judgments to only the licensed professionals. Of course, you'd have to comply with the anti-kickback and Stark laws. Integrated delivery systems are also possible, where you have a physician practice and perhaps other types of providers that are in the group all under a single corporate umbrella. You'd still have to comply with Stark. Usually the anti-kickback laws are not an issue in an integrated delivery system. I would urge you, though, to segregate out the performance of the Independence at Home program so that when these programs, I didn't say if, but when these programs achieve savings, you'll be able to show the savings were due to your efforts. The dues in developing a program, an Independence at Home program, as I say, think broadly. Think beyond Medicare and think of Medicaid and private insurance. Make sure the objectives right from the beginning are better health care at lower costs and the provision of medically necessary services. You cannot find yourself in the position of putting together an organization that is designed to deprive medically necessary services from being given to patients. Ensure that the legal arrangements all comply with state and federal laws. That's certainly would be true of any arrangement, particularly this one. And contracts really must address the distribution of savings and losses if you want to avoid litigation down the road. Don'ts, I would urge you not to place all your eggs in the Medicare basket. As I say, for the demo, it's a 3-year demo, which we hope we can shorten. But you may not get chosen. Certainly don't put yourself in the position of being accused of paying for referrals. Implement an Independence at Home program. Don't do it. Don't implement such a program without competent clinical, financial, and legal advice. These are new entities, and Congress is creating lots of incentives for entities like this. But there are still laws that you need to steer past. And don't fail to have contracts that specify the services, how you'll be paid, and the distribution of profits and losses. And don't fail to collect data on the success of your program, because if you are in a venture with some other organization and it doesn't go well, you want to make sure that if you exit that relationship that you take the data with you, because there will always be a place in this environment for programs that reduce healthcare costs where they're the highest. And with that, I'll turn it over to Brent.
Great.
Hi, and I'm going to get started and introduce Brent as well. This is Gary Swartz.